I too want to congratulate Chaz on its 50th birthday. And I've decided after being here for like, I don't know, about 15 hours or something, that I actually prefer institutional 50th birthday parties to individual ones. We've heard no goofy poems or songs yet. That's a good thing. When you have a 50th anniversary for an institution like Chaz, it is a sign of a robust institution that's really going to move into the future in a strong way. When you go to a 50th birthday party, it starts with things like prostate jokes, and then it declines from there. So I'm really glad on that score. And the inevitable decline of a 50-year-old is just not that much fun to celebrate after the goofy songs are done. And so I'm glad to set a different tone here. What I'm going to try to do is I'm going to sort of walk you through a little bit of data on the contours of the uninsured sort of vulnerable populations, much of which you've already seen. Talk a little bit about the roles of Medicaid and private insurance in sort of the coverage expansion and how it applies to poor, sick, and disabled people. And then sort of talk a little bit about some of the policy choices, some of the implications of that information. And really what I'm going to try to do is make 3 points. The first one is that I think there are surprises in the health status across the income distribution at the lower end, and that's going to be important for the consequences of the coverage expansion and the exact trade-offs that policymakers have to make. The second point I want to make is that expansion affects both the coverage rate, but also the content of coverage. And while that's been talked about a lot recently in terms of why you might expect premium increases, it's been talked a little less when you think about what is in the Affordable Care Act for helping people who are sick, poor, and disabled. And then finally, I want to spend a couple of minutes talking about some of the implications of some of the potential choices and the interactions that coverage expansion has with other things. And one of them is state government budgets. And the other thing is how things like Medicaid policy is going to affect the conduct and outcomes for the exchanges. Okay, so this is relatively well known, but I just want to highlight it here at the beginning, which is that, in fact, when you think about the targets for the coverage expansion, you're picking up about 90% of the people in the subsidy zone. 50% of people are under 138. Of the uninsured people have incomes under 138% of the federal poverty line. 90% are under 400%, and then about 60% of those who are expected to potentially gain coverage are single childless adults. Okay, we know that, but it's important, and I want to sort of establish that on the bottom line. Okay. So let's start to pull apart people in terms of their health status and other sort of characteristics of vulnerability across the lower part of the income distribution. And I'm obviously aligning it to sort of milestones in the coverage expansion. So if you look at this table here, what the surprising thing to me was actually that the people between 133% and 400% of poverty are actually typically have more sick people in it. I mean, have a higher percentage of sick people. And that, in fact, under 133% of poverty actually looks a little bit healthier. And I'm going to sort of break that apart for you a little bit more in a second. But really, what I'm trying to set up here is the idea that as states and exchanges and the government make different choices, and you potentially have the opportunity to sort of move some of these people around at the margin, it actually matters in a couple of different ways. And it matters first because there's an interaction between Medicaid and the exchanges. And second of all, because of the flexibility in Medicaid to sort of choose plans that differentially match the needs of different subpopulations, you may have a different set of opportunities if you cut things one way than if you rely more heavily on the exchanges. Okay, so I showed you 133% and above and 133% below. Let me now just go below 100% of poverty. And what you see is that about 26% of the population have multiple chronic conditions. And 15% have 2 medical conditions or more, and then about 11% have both a psychiatric and a medical condition. And this is important because people with mental and addictive disorders are very heavily represented among the low-income uninsured. And then about half have a chronic medical condition, and about 40% have no doctor visits in a year. So they don't touch the medical care system a lot. Okay, so what if you put these two slides together? What it tells you is the portion of the income distribution that's actually pretty healthy is that between 100 and 138% of poverty. Okay, so you got sicker people below and you got sicker people above. Okay, this breaks things down a little bit further. And what I want to do, I'm using this to sort of highlight that point I just made. Here what we've done is we've taken MEPS data, and we've looked at the representation of different illness groups. And we're focusing on 4, mental disorders, diabetes, cancer, and heart disease. And what you can see is that mental disorders and diabetes are quite overrepresented in the below poverty group. That all of them are underrepresented in that 100 to 133% group, and then cancer and heart disease are a little bit overrepresented in that other group. So they're different. You have sicker groups on both ends, but what they're sick with is actually kind of different. Okay. So these are the, this should all be well known, these are the channels into being uninsured. And really what I want to highlight is that as we think about these channels, the idea of trying to match services to the needs of these vulnerable populations are differential according to which channel you go through. And then the other thing I want to highlight is that these programs interact, because really they're sort of potentially aimed at some common groups. There will be opportunities for example, if states choose not to expand Medicaid, the exchanges can pick up some of those people. Okay, in addition to sort of the basic coverages, there are a few things that are in the Affordable Care Act that help sort of touch people with particular disabling and chronic conditions. The first is the Mental Health Parity and Addictions Equity Act, or Wellstone-Domenici, which was enacted in 2008, but which the Affordable Care Act overlays on both the essential health benefit and the alternate benefit plans under Medicaid. And I'll show you a little bit more about that in a second by giving you an example of what that will mean for coverage and quality of coverage. The second is the rules around the Modified Adjustable Gross Income, or MAGI, means that there's flexibility for people who have special healthcare needs and disabling conditions to sort of choose different ports of entry into Medicaid, even if they're only covered in the expansion population, which creates an opportunity, again, to match needs and coverage in a way that you won't have on the essential health benefit side. And then third is this is sort of a kind of a nerdy little thing that I just can't help but raise it. There's a provision called 1915I in Medicaid, which what it does is it creates opportunities to more flexibly cover people with disabilities of all kinds and to offer a different package of services that has typically been allowed under Medicaid, and it allows people to be made eligible for these services up to 150% of the federal poverty line. So it's actually a great opportunity. So that's the good news. The bad news is that very few people are taking it up. But nevertheless, it is an opportunity, and states are starting to figure it out, and there are a lot of efforts sort of currently underway to try to figure it out. Okay, so let me give you, can you read that? Yeah, okay. Let me give you a quick example of what all this does for at least one fairly large and significant vulnerable population, which is people with mental disorders. And what this is actually data from both a paper and some work that Sherry and a woman named Kirsten Baronio put together as part of health reform, and we've sort of been making use of it. Now, the interesting thing is that obviously the Affordable Care Act covers people who were previously uninsured and covers them at parity. So that's the good news. But the parity legislation also means that people who are currently insured now have to have parity coverage, and because parity has been extended to the small group and individual markets through the mandate, it actually means that people who had insurance coverage but had no mental health coverage, of which there are several million, now will have decent mental health coverage. So in fact, at the end of the day, there's going to be about 62.5 million people affected by the combination of the Affordable Care Act and parity coming together, and only 27 million of that total is just purely uninsured. The rest of it has to do with extending the quality of coverage and the reach of coverage through the interaction of the two statutes. And so that's an example of how that happens. And likewise, you have that kind of thing going on with the 1959 and other Medicaid provisions, which is the opportunity to do things differently, even as you cover more people. Okay, now, when you think about things like insurance regulations, mental health parity, you need to remember that these are, for better or for worse, they're regulations by analogy. And so the good news is that you have to handle things like behavioral health and addictions and medical surgical care in the same way. The bad news is that if you're not doing a very good job on medical surgical, you're not going to be doing a very good job on. And so, in fact, what you're seeing is, for example, the essential health benefit is going to get most of acute and most of post-acute care underneath it. But in fact, when you have a disabled population, there will be essentially no long-term services and supports. And because that population tends to be a bit overrepresented in the low-income population, the work is incomplete. And so that has a number of implications in terms of what the continuing role of state funding and things like that are going to be. Okay, so now let's turn to the design choices. So first question is Medicaid expansion, yes or no? And you know, the dominoes are starting to fall, but we still don't know the answer. But then the question is, if yes, the state has sort of three sort of avenues for making choices. First of all, they can just say their expansion population will be covered by their state plan, that they will handle the expansion population the way that they handle their state plan, which means that the long-term services and supports and all that will be there in the same way it's there in their state plan. And there are some states considering doing that. In fact, there are a number of states who actually have already started to put their plans in place to do that. So that's one option. The second option is to use a benchmark that's specified in the law, which is essentially decent private insurance, such as federal employees' standard benefit plan package, the largest HMO in the state, or the state employees' health benefit program. And then the third is to choose one of those, but to allow flexibility for flexing out the benefit to touch on especially populations with special health care needs, disabled people, people with severe mental illness, HIV, and the like. And there is, again, there are some states that are considering doing that, but you can imagine already this thing's starting to already get pretty complex as you start to think about it. Then the other big choice is sort of what you do on the benchmark for the essential health benefit. And there are a variety of choices. The guidance and the rule to date focuses on, again, sort of private insurance. The scope of services is focused on private insurance that's defined usually for the larger small employer plans. But along with that, you have to worry about things like, risk adjustment and functioning of the exchanges and the way that whether or not you're going to exclude plans, what kinds of premiums you can get, and the like. So, if the state chooses not to expand Medicaid and the exchanges pick up that population between 100% of the federal poverty line and 400%, you're going to have two consequences based on the data that I've just shown you. The first is that some of the most vulnerable uninsured people, particularly those with diabetes and mental disorders, are going to be sort of left out. The second is ironic, which is the risk pool for the exchanges may actually be sweetened. And I'm going to show you that in a second, because what you're doing is the marginal people that you're bringing in that are coverable under the exchanges but not covered by Medicaid in the absence of the expansion are in general healthier. Then the second issue is creating matches to vulnerable population is a bit tricky here. And the ability there is flexibility on the Medicaid side to actually do that and to do that well, but as soon as you try to balance that with not going with the full state plan option, you start getting things really complicated and having sort of multiple plans within your exchanges and all kinds of variations on the theme, and that doesn't always work out so well. So let me highlight the point I made about sweetening of the exchanges. So these are simulations that are made on the basis of MEPS. And what we've done here is on the left side of your picture, you can see that that is the exchange population, the average cost of the exchange population when there's no expansion and everybody is put into everybody who can be put into the exchanges are put into the exchanges. And so you see that the dark orange line on the left is lower than the dark orange line on the right, which means that the exchange pool has been sweetened, and that's because the marginal cost, which is the lighter colored bar on the left side there, is actually lower. And again, that highlights the fact in a simulation that takes into account a lot more variables that in fact the cost of that population that would have been covered by Medicaid that goes into the exchanges is lower. Okay, so what are the consequences for the states? The first thing is CBO estimates that about 93% of the Medicaid expansion over the first 9 years is going to be paid for by the federal government. So the actual direct costs are modest. Now, the Urban Institute has estimated that somewhere between 26 and 50, and I don't understand why people always double their estimate, but it does seem to be a law of making projections in Washington. But anyway, but somewhere between 26 and 52 in uncompensated care costs will shift to the federal government. And among the largest areas are behavioral health care, mental health and substance use. There's about $20 to $25 billion a year that comes straight off state budgets in that area. And the estimates are that, 2/3 to 3/4 of that will now be covered by insurance. And so there are sort of some big shifts, particularly if you manage to pick up that group that is heavily represented among that population. So there are some really sort of important cost shifts that occur here towards the federal governments if the states want to expand. Okay. So I think that, in a sense, the Affordable Care Act is based on the notion that insurance markets have always hurt the sick and the disabled more. And everything that you've seen from the initial consumer protections, the high-cost health plans, and a variety of the Medicaid provisions and sort of the parity overlays is really aimed at recognizing that. And the coverage expansion, therefore, is going to disproportionately, in a positive way, affect people who are sick, poor, and disabled. Now, what I find is that there are sort of some surprising interactions possible. And depending on how this plays out, you have this sort of interesting trade-off between some improvement in the functioning of the exchanges and some big changes in some big implications for actually who you cover and what might happen to state budgets as a result. And there remains a lot of uncertainty about the degree to which states are going to be able to develop policies in a practical way that are going to allow the best set of matches to be made between the needs of these populations and the coverage that's going to be offered to them. You know, one of the things that you should take a little bit of solace in is that if you think about the illnesses that make the people between 133% and 400% of poverty the sickest, cancer and heart disease, those are going to be pretty well covered by the essential health benefit. The ones who are going to be less, which are the longer-term chronic and disabling conditions, mental disorders, addictions, diabetes, et cetera, those are on the Medicaid side. So the failure to do a Medicaid expansion or the failure not to be flexible around what you offer those populations actually might actually create a missed opportunity to really do a good job with those populations. Thanks a lot.